Thank you, Mayor Phil Goff. Well, now it's my pleasure to introduce our keynote speaker for the evening, Dr. Sam Tsemberis. Sam founded Pathways to Housing in New York City back in 1992. He's on the faculty of the Department of Psychiatry at Columbia University Medical Center in New York. During his time there, he developed the Housing First model. Housing First provides immediate access, and this is the key, immediate access to permanent supportive housing for people who are homeless and who have added challenges such as mental health or addiction problems. The Housing First approach has been operating internationally since the early 1990s, and the good news is it's been evaluated as one of the most effective programs available for addressing homelessness. Ladies and gentlemen, a warm round of applause, please, for Dr. Sam Tsemberis.
Thank you, Greg. Mr. Mayor, ladies and gentlemen, members of the council, it's a great pleasure to be here this evening to be celebrating with you this initiative of Housing First Auckland. It's remarkable to be back in your very beautiful country, only 18 months after the initial visit here, where the idea of talking about Housing First was conceptual and seemed like a good thing to do. And here we are 18 months later with a government commitment, an NGO commitment to start this rather significant and impressive initiative. And it's having met over the last 4 days with the people who will be working in it, I can assure you that we're in for some great results. I thought that it might be useful to I wasn't quite sure because, explaining Housing First is very simple. And I was thinking maybe it would be useful to talk to you a little bit about why it took so long, why we've had homelessness for as long as we've had, and how we're going to go about solving it. Just to give you a bit of a historical perspective that might help us also to avoid the mistakes of the past and take the lessons learned going forward. There are many reasons we've had homelessness since the early 80s in America and 90s in Canada and Europe and as it's trickled over into Australia and New Zealand. But I would say there are two major reasons that I would like to focus on this evening. One of them is that because homelessness has been part of the landscape for so many years, decades, that we have learned now an entire generation of people sitting in this room, people under 25, have grown up believing that homelessness is part of the landscape, and that they have learned also from the teaching of their parents that it's better not to look at people who are homeless. We have, all of us, learned to avoid staring. It out of politeness, out of respect, out of the pain that it causes to see someone on the street suffering. We have learned to look away. And similarly, the people who are homeless have also learned to hide. So there's been a mutual social contract, unspoken, where we have not really been looking at this problem. And I'm happy to say that this initiative, to me, signals the beginning of looking the other way. It's a difference between the child being told no, no, because the child's response actually is what has shut down. When you're walking down the street and you are with a child who's 9 or younger, their natural response is shock. And why is this person here? And the parent will say, don't look now, let's walk the other way, avoid this. And in that communication, they have learned over time to walk away. Shutting down a part of their humanity, of their natural human response of the shock that we all initially felt but have learned to turn off. That's the price, I think, psychologically that we pay in tolerating homelessness. It's costing us part of our humanity in allowing it to continue. So I want to thank each and every one of you who are here tonight, because you are not looking the other way. You are here to talk about this issue, to face this issue, to celebrate a community-wide commitment to looking at homelessness, and acknowledging that there's a problem and looking at it is step one to progress. So thank you for that. The other problem, the major problem, is really historical. And it goes back to when homelessness started to begin with, and why it started and what our response was. Now, the mayor said he grew up in Auckland where there wasn't homelessness, because homelessness wasn't really part of the lexicon until the early 80s. Homelessness was episodic. There were people that were homeless during the Great Depression, but this era of homelessness as we have it in the Western world is really credited to a Mr. Ronald Reagan from California. And if any of you had the opportunity to see his biography, he is at one point in this Public Broadcasting Corporation biography of Ronald Reagan credited with the creation of homelessness. How did it happen in the early 80s? Well, the Reagan administration had a policy of supply-side economics, trickle-down theory, some of these terms that you've heard about. If you make wealthy people wealthier, then the wealth will somehow fall out of their pockets, and the rest of us will also benefit by the pennies that we can find on the street just following rich people. Well, I'm oversimplifying it, but I'm not an economist, I'm a psychologist. So that theory resulted in a public policy that was a disaster on many levels, but particularly for social services and what is called in the States public housing or social housing, affordable housing. The government in the United States stopped building public housing in the early 1980s under that administration. They went from building 350,000 units a year to 50, where it continues to remain today. No administration since then has ever recommitted to that. The failure to support people who are poor by having social or public housing was taken as a warning to those that were on the margins. And not surprisingly, we began to see people who were homeless literally on the streets of the major cities, Los Angeles and Chicago, Detroit, New York. And the people that were most immediately and most brutally affected by this policy were people that were on fixed income. This same policy was adopted by Maggie Thatcher, Mulroney in Canada. Years later, there was a kind of a similar policy approach in Western countries. And that approach began to create income disparity across these countries. The United States difference between the rich and the poor in the 70s was somewhere around 30%, and now it's up around 55%. New Zealand looks more like Scandinavia in that regard, that there's some income disparity, but it's on the lower end of the scale. And I would encourage you to think about the policies that would keep that disparity as low as possible, because as income disparity increases, homelessness increases, poverty increases, and also a government's commitment to building social services decreases. So it's a perfect storm for those that aren't doing well. When the people who suffered with the lack of economic support began to appear on the street, what was clear about them was they had additional problems besides poverty. People with mental illness, people with addiction, And there was a public outcry to do something about the people that were literally raining out of the sky and onto the streets. And the response was an emergency response, like the Red Cross after a hurricane, that we were having significant problems and these people looked ill and we have to take care of them. And these armies of caretakers that included social workers and nurses and doctors did what they know best, Doctors Without Borders. Only they didn't have to go outside their own borders to do the treatment. It was a small nation in internal exile in their own country that needed the treatment. And they did the best they could to treat them, believing that treatment was the way back to housing. They had assumed that it must have been the mental illness or the addiction that caused the housing, not a misguided social policy that resulted in homelessness. So the industry that built up over the years to address homelessness was actually founded on a misdiagnosis of what the problem actually was. No amount of fixing people, of curing people, of counseling or addiction treatment was going to help them to pay the rent or to have access to housing. So the intervention was helpful but did not address the core issues of the problem. The investment in emergency housing, transitional housing, all kinds of programs aimed at improving the individual, often also believed to have made some poor decisions on their own. So it was not only improving their clinical status, but it was also about improving their judgment in some ways. Somehow the person was responsible for their homelessness, and we sought to help them understand what responsibility was about. It worked. It worked well for many who could tolerate and manage the treatment and eventually get into supportive housing, but not for all. There was a small group of people that remained stubbornly on the street, could not or would not manage the treatment first, then housing approach. This group of people that actually represents only a small percentage of all people who are homeless, maybe 15 or 20%, is the group that in the public's mind and then in the media's reporting and in the public policy realm became the group that represented homelessness and the problems of homelessness, which it only represents a portion, leaving out families, youth, and other groups that are homeless or at risk of homeless as well. But this is the group that most people think of as the issue with homelessness. This group that stayed out of the treatment system, that could not make it, can be thought of as outliers. They didn't fit in. They didn't fit in for any number of reasons. And outliers, we have a great debt to outliers in all social sciences, because outliers, Dr. Singh tells us, teach us the normals in a population teach us the rules. If you do this, then if you give the person aspirin, their fever goes down. That's the norm. It's the outliers that teach us what doesn't work. And this group of people who had remained homeless for a long time were the outliers in a social service treatment response that taught us what was wrong with the existing system. These were the folks that helped us to understand the flaws in our logic in approaching a complex problem with a treatment-first approach. It was this group that was fundamentally responsible for helping us to develop the housing-first approach, because this group understood and could articulate what it was that made sense to them from their own perspective. So the first thing about Housing First is that it was not ever an intervention that was designed in a conference room or in a planning room and visited upon homeless people. Housing First is fundamentally an approach to working with people who are homeless that includes them in every aspect of the conversation. What they want, what their preferences are, what their priorities are, And the program is actually designed to honor those preferences. It's a ground-up intervention that the people on the streets of New York City would be very pleased to be here this evening, seeing it being adopted, all the way in New Zealand. But it came from the streets by people living on the streets. And frankly, I think that's why it's so effective. It's a very consumer-driven, client-driven approach that works well in most businesses, including the social service business. The program has 5 dimensions. Client choice is a core part of it. The person is invited to articulate their preference in the sequence that they want and what matters to them most. That's how we got to Housing First. Most people who were homeless, these outliers that we spoke to, were most interested in a place to live first. So housing first, not because we thought it was a good idea, it was the thing that was most urgent to the people on the streets. The philosophy of self-determination is a very core dimension of the program. And self-determination means empowerment to make decisions and be heard. Self-determination means having a voice, a democratic process of working with people where they have a say-so in the treatment. And it also includes a dimension that some have called distributive justice, which is if you're working with people who are poor and they have other problems in addition to the poverty, it's useful to address the other problems as well, but if you're going to provide a comprehensive approach, you also need to address the poverty. It's not enough to just give counseling to someone who is poor and suffering with addiction. You also need to pay their rent. The type of housing that people wanted when given the choice was a place of their own. People wanted a real home. They didn't want to live in a program. They didn't want to live in housing where also social workers lived for treatment. They wanted to live in housing and go to treatment maybe. There was a clear feeling of not wanting to be identified as needing special housing or being in some other ways identified as people in need of treatment. The idea of social inclusion is woven strongly into that. So people had their own place, typically an apartment of their own, and they had people visiting and supporting and treating and helping them with all of their other needs. A program that is housing first, but not housing only, and includes all of the supports that the person needs. If people lose housing, if they need to relocate, if they are evicted because from the streets their friends moved into the house with them because they couldn't refuse them, the treatment team will work with the person and find another place. A place that often people do better at the second time because they've learned a lesson from the first time. It's not a program that is punitive, so that if people make a decision, which they're encouraged to do, and make a mistake and fail at it, their failure is seen as an opportunity to learn how to do it better the next time. And in fact, people that go to a second apartment in this program often do better than they did in the first. So that the learning is part of it, we have to allow the dignity of failure for the person to have that opportunity to learn. But the commitment is not to the apartment. If the person loses housing, the support team will follow them. If a person gets arrested, if the person goes to the hospital, whatever disruptions there are in housing, the commitment is to stay and work with that person for as long as they need it. So that the housing first, sometimes misnamed, is really fundamentally about people first. It's a commitment to work with that person in a constructive, helpful way until they find their way and don't need our help anymore. Another dimension of the program is recovery orientation and a support for social inclusion. This is particularly relevant here because of the cultural sensitivity and respect to the Maori culture. I have not learned enough about it, but the little I have learned about Maori culture, it seems a wonderful fit from a values perspective with an approach that is about self-determination, that includes whanau, whanengatanga, and other concepts that are about family, kinship, connectedness. It is very much in the spirit of community and social inclusion. So that, and this is an important consideration given that the people who are really targeted by this Housing First initiative, Auckland, vast majority Maori descent. So that, and it may look different and it may be shaped in other ways in terms of housing choice and the way that the services and the type of services are determined. But these principles of choice and separation of housing and recovery orientation are general enough and I believe can be applied and adjusted to fit the cultural needs and preferences of the people that they serve and the people that are working here. Just a couple of more comments about this approach, which is, one is that it's an evidence-based approach. I think the reason that I'm here talking to you today is that this program has been studied a great deal in small and large studies. The largest, I would say, most recently, was a study that was done in Canada where there was a national implementation. It was 5 cities, not 5 organizations like we have here, but similar structure. A large number of people, 2,000 Canadians plus, were randomly assigned to either the treatment first then housing approach that I described earlier, or to the housing first and then treatment approach, and they were followed for 24 months. The results of that study showed that the people in the housing first approach were stably housed quickly and stayed housed about 80% of the time, and the people in the stairway approach only made it to about 40% of the time. This was a huge difference in outcomes for social science studies that are usually much smaller percentages. There were significant improvements in the quality of life of the people in the Housing First program. There were some cost offset settings. One of the things that isn't commonly understood about homelessness is that it's really, really expensive. It's really expensive for the people who are experiencing homelessness. They have nowhere to put their food. They have to buy food all the time from the grocery stores or things that they cannot store. Everything is at an expense for them. They are struggling daily economically. But strangely, what we think of as homelessness and disconnection, it comes also at enormous cost to taxpayers in the sense of the services that are not perhaps visible on a daily basis are typically acute care services that are very expensive. People get sick or they get into accidents, they are in emergency rooms, they are in inpatient services, they are transported by the police, they are going to soup kitchens and other programs. If you tally up the cost of someone being homeless that is needing services over the course of a year, it can easily come to $100,000 or $200,000 a year in services alone. And this Canadian study and other studies that have looked at the frequent users of acute care services report the same kind of data. Putting a person in an apartment with the support services, which ranges anywhere between $15,000 and $25,000 per person per year, and results in a tremendous cost offset on the reduction of the acute care services. So yes, it's an intervention that may cost money, but is it actually costing us any money overall? And the answer is no, it's actually saving us money in addition to everything else. One of the challenging conversations about Housing First is, can we find enough affordable housing in Auckland to house 450 people in the course of the next 2 years? And the question of the affordability of housing is a large and important question. The answer, you've already heard from the mayor, is that we don't have enough social or affordable housing overall if we're going to address the 20,000 people who are homeless or at risk of homelessness. But an initiative that is only focusing on 400 people, 200 people a year, we can find 200 vacant apartments tonight. So the scale of the program, because it's focused very narrowly on this small subsample of homeless folks, is totally manageable with the right rent supplements in the current housing market. It will solve homelessness for those 200 individuals. It will not solve the larger issues and policy issues of affordable housing in Auckland or New Zealand. That is a separate and very important conversation. But we don't need to solve the large question in order to help these people on the streets today. One of the more promising aspects of this intervention is that because you have been so sensible and in managing not to have the kind of income disparity experienced by other nations, the actual number of people that are chronically homeless in your city and in your country is rather small. And small is great because it's a solvable and manageable problem. And I think tonight you are beginning the initiative that will actually end chronic homelessness in New Zealand. And I wish you all the best. Thank you very much.